Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello, everyone, and welcome back to Cardiovascular Matters. You know, we've put together more than a dozen episodes now, and the viewership has been good. I appreciate everybody that's been listening to the channel and making comments. You know, the whole premise of this was to provide information for family members and loved ones that are going through a medical event like this. And you know, I was a rep in working in the labs, medical devices for over 40 years, and I would often walk in and hear family members talking about, you know, I really don't understand what the physician was saying, or I had these questions, or I couldn't hear what was being said. And you know, the premise of this is to provide more information and to kind of slow things down and allow you to really learn about each one of these topics. So thank you very, very much for supporting our channel. Be sure and like and follow our channel, and turn on your if you follow us, you'll get indications when these episodes drop. We try to drop one each week. We're getting better at that, and Dr. Walker has an incredible intensive travel schedule, so we always work around that, and that's fine. But anyway, hope you enjoy the upcoming talks from Dr. Walker and Cardiovascular Matters. Thank you, everyone. Well, welcome back, everyone. Last week we discussed the prevalence of peripheral artery disease in the legs, and Dr. Walker went over some simple diagnosis techniques that are used to determine if patients have that or not, and then went on to talk about the actual things and treatments that can take place, you know, that don't involve a lot of money, just involve a little discipline and understanding amongst the patients to take charge of their own health care in terms of walking, stop smoking, all these things that you need to do to improve your health. Today's podcast, or the content we're going to be talking about, is taking it one step further. And, you know, as you look at the disease progression, you know, the next step is what we call critical ischemia. And I'm going to let Dr. Walker explain that, and I'll have a few questions along the way. Thank you, Dr. Walker.
So, Terry, critical limb ischemia was really a term coined for true ischemic rest pain, where you have to hang your legs down, or else you hurt, even if you're laying flat. Mm-hmm. You need gravity to get that little extra bit of blood to where your legs don't hurt, or non-healing wounds or ulcers or gangrene. And unfortunately, it is a huge part of my practice. I get patients from all over the world sent to me for treatment of critical limb ischemia. Now, historically, when critical limb ischemia occurs, the most important treatment has been, of course, to restore blood flow. And historically, that was surgery. And surgery for critical limb ischemia was initially basically two things. One, either doing a bypass around the blockages, or an endarterectomy of the bigger vessels, where one goes in and scoops out some of the atherosclerosis or clot that's there, and that restores blood flow. Those are big surgeries. However, they're certainly good, and I certainly send some patients sometimes for those treatments. But for instance, to do a bypass, you need to have a patient who is capable of withstanding surgical stress, because it's not a small surgery.
Big surgery.
You need to have good outflow vessels, typically a reasonable conduit, and a lot of patients don't have those, and they don't meet those criteria. So interventions were created, and the first person who did this was a Dr. Dotter, and he did this really quite some time ago. He's called the father of intervention. He was asked to do an angiogram of kidneys on a patient who had blocked iliac arteries, and so he placed a catheter through a blocked iliac artery, and he did the angiogram. But when he saw that patient in follow-up, The patient says, "Doc, that's great. You could get those images and they fixed my kidneys." He said, "But my leg doesn't hurt now." And so Dotter had a light bulb that went off. He realized that by pushing that catheter across the blockage, he had somewhat opened the vessel.
Restored flow.
Yeah. Now, a catheter going across a vessel, though, you can't really make a vessel as big as the vessel is because you're only making a hole the size of the catheter that you push. Okay. And so ultimately, we needed to do more. And Dotter had, unfortunately, he died before he could do all the things that he had envisioned. But he had envisioned the concept of using a balloon because you can make a balloon much bigger than the catheter. He had envisioned the ideas of perhaps even putting something to hold the vessel open if the vessel had a lot of elastic recoil. Well, others made those. So the first, the balloon Gruncic came up with, and then several others came up with different stent designs, Palmaz being one of the most important there with his balloon expandable technology, and really made stenting a mainstay. Then for the arteries further down in the legs, not those up in the abdomen, we needed stents that would not be crushed because those arteries are not so deep. And if you use a balloon expandable stent, the way you place it is to stretch it beyond its elastic limits. But if you push it from the outside, you will shut that down. Right. So we needed spring-like stents that open up. Then a man named John Simpson came up with an idea of, why don't we remove the plaque? And so that created a field called atherectomy. And we have many atherectomy devices today. His original one was a cutter that was used to go in and scrape out plaque. But we now have grinders, we have laser, we have many, many different forms of technology to remove plaque. And then more recently, we have something called lithoplasty, just like using the shock waves for kidney stones.
Right.
This is being used now in arteries. And so when arteries have a lot of calcium in them, it's very difficult to get a good result with just a balloon. But if we use this lithoplasty, then we can break up some of that calcium that's in the vessel wall. It doesn't seem to go downstream. It just seems to soften up the vessel, allowing us to get a better vessel, to get the vessel open. Well, really, these techniques have been transformative because using these techniques in combination, we're able to almost always restore blood flow. Now, all too unfortunately in today's world, when people present with critical limb ischemia still in the United States, about half are told their option is amputation, and they don't have a vascular consultation. I think that's an error. And I think we should do better than that. I think we owe our patients more than that. Right. Certainly, bypass can be a great treatment, or these interventions can be a great treatment. And there's been some controversy recently in the press about restoration of blood flow. But there is no controversy that being able to keep your leg is better than losing your leg. If you lose your leg, it portends a much worse prognosis for life and death. There's tremendous problems with mobility, quality of life, and even life expectancy once you lose a leg. And so how big a problem is this? Well, of people presenting for the first time with critical limb ischemia, with advanced techniques of surgery and intervention, because those second things I've mentioned, the interventions, are all done typically through a needle stick, and patients typically can go home the same day if they don't already have a lot of tissue damage. Obviously, if you have gangrene, you have to get blood flow, and then you have to do something to remove gangrenous digits. But even with that advanced disease, more than 90% of those people can achieve limb salvage. And in my opinion, it's unconscionable to proceed first to major amputation in that subset of patients. Now, there are some people who absolutely need an amputation. The whole leg is dead. At that point, there is no flow. And if you try to restore blood flow, it may result in poisons being released from those tissues that can kill the kidneys and actually kill the patient. So I'm not one of those patients that say there's never an indication for an amputation. But I do think they're overutilized in the United States at this point. And I think we really have to look at saving limbs. And if we're going to do that, once again, it's dotting I's and crossing T's. First off, the patient must be on all the appropriate medicines. And in today's world, one of those medicines may be a class of drugs that we call the factor 10A inhibitors. There is a lot of data that in patients who have peripheral arterial disease, if we use factor 10A inhibitors, that we make them less likely to die of heart attack, less likely to die of stroke, and less likely to lose their legs. So medical therapy is one of the first things that we need. They should be on antiplatelet agents as well, should be off of cigarette smoking. All of those things are important. But then we can utilize these other techniques. Now, I've told you in the broad sense what we have, but what I didn't say is now not only do we have balloons, we have scoring balloons, we have lithoplasty balloons, we have drug delivery balloons. When I told you stents, we have self-expanding and balloon expandable, but we also have drug-eluting stents. We even have stents that go away over time. These stents are bioabsorbable. With atherectomy, we have at least a dozen atherectomy devices right now, and there are many more being developed. So we have many tools, and right now, we know that there was one randomized controlled trial with atherectomy that was using 308 nanometer excimer laser in opening up stents that had become blocked. And that was clearly far better than balloon angioplasty. And so that's randomized control. No one can doubt. But we have reams of observational data that atherectomy helps patients. There are large registries showing that patients presenting with critical limb ischemia seem to fare better long-term if they're first treated with one form of atherectomy, removing some of the plaque, followed by these other techniques and technologies that I've mentioned. So I don't think there should be much controversy there, but there still is, because it said, well, we don't have randomized controlled trials. Sometimes those are almost impossible to get. For instance, we have no randomized controlled trial that a parachute works. And the reason is no one's going to volunteer to be the control arm who jumps out with no parachute. Do parachutes work? Of course they do. But we don't have a randomized control trial. We have observational data. We have observational data knowing that those people quite usually do well. And we have reams of that with atherectomy at this point. Now, one of the problems and one of the other criticisms is that patients presenting with critical limb ischemia often need repeat reintervention. That is true. Peripheral vascular disease is a progressive disease. That is why it is so critically important to have them on all the right medicines and preventive measures first. We have to double down on that. That's very, very important. But let me explain something that's very important. Once someone has developed critical limb ischemia, regardless of if one goes straight to amputation or intervention, that patient is a more expensive patient to take care of. If we cut their leg off, it doesn't end right there. They continue having leg pains. A third of those go to a nursing home, and there are tremendous nursing home costs. That doesn't count if they do go home, all the costs they have to bear. They have to build wheelchair ramps. Other people lose work. Mary Yost has written a beautiful article on this, and the cost of amputation is far more than the cost of limb salvage, without a doubt. However, it is so important when one considers limb salvage to make sure things get done right, because the better things are at first, the better flow is established, the better tools being used, using what I call patient-specific, disease-specific therapies. When that is done, we can achieve really good results. I can speak of reams of patients who one procedure on each leg saved both legs. One man right now was told at major prestigious institutions he needed both legs cut off above his knees. This man had been running up until the time he had gotten sick. That same man, 11 years later, has both of those legs and is able to walk. And there are many patients in my practice like that. But there are also many patients that I do have to go in several times to repeat a procedure. Now, sometimes that's just the disease process itself. Unfortunately, sometimes I've been unable or incapable of communicating how important it is to take medicines and to not smoke. Right. And I try that very hard. I really put major effort into that because those things are very important. But limb salvage is a real thing. It's a real thing. And certainly surgical revascularization, certainly interventional revascularization, or sometimes a combination of those two is crucial. Mm-hmm. But we can do it. But what has to happen is we have to get to that patient as soon as possible. When we wait very long, if someone has early gangrene or an ulcer, all of a sudden, let's just say the leg gets infected. Mm-hmm. Prognosis is worse. Mm-hmm. Once that infection gets in there, much, much worse. Even with infections, usually we can save the limb, mm-hmm. but it is less frequent than if there is no infection at that point. So obviously, it's like anything else. People must take this disease process seriously, and they should seek help. Now, one of the things I worry most about, however, is the cavalier attitude of society, but also the cavalier attitude right now, unfortunately, of many healthcare practitioners, thinking this is just a disease of the legs. They don't give it nearly the importance of other things. I've heard some people call critical limb ischemia the equivalent of cancer of the blood vessels. It's not cancerous. Let's start with that. It's not unresolved proliferation of cells that can't be controlled. But you know what it is? It's more deadly than almost any form of cancer. Only lung cancer and pancreatic cancer really have higher mortalities than critical limb ischemia, peripheral arterial disease. And yet many people, really fear those tremendously because of what they've heard and don't really take critical limb ischemia so seriously. It's something we have to educate our populace about. It's something, hopefully, with the right preventive measures early on, once we diagnose peripheral disease, we can help. And maybe, as I've mentioned before, this is a disease, critical limb ischemia is very, very closely associated with diabetes, where if we start treating people earlier with some of the diabetic drugs that have been shown to lessen progression of atherosclerosis, we might really have a big win here. And keep in mind, historically in treating diabetes, our focus was on controlling blood sugar. Now we've got to do more than that. We've got to prevent cardiovascular disease, and not all of the diabetic medicines do that.
That's great. I had one just question. You've probably done as much or more critical limb ischemia cases than any physician I've ever come across. And when you're planning an intervention, in the past, we were happy just to get one really good vessel open with bounding flow all the way to the foot. Is that still the case today, or do you just look at the ischemic areas and tackle, create a plan associated with that?
Yeah, that's a great question, Terry. And there's raging debate amongst interventionists and surgeons. Historically, surgery just can get one vessel open.
Right.
If they're going, they'll bypass one vessel.
Right.
But because it's a conduit, it has a little less risk of blocking up that one conduit. And so, that's what they did. Now, intervention has a little higher risk of returning blockage. And so I try to open up more than one if I can. I'm trying to gild the lily, if you think about this. I'm trying to make sure that I protect against if one of those blocks up to improve, overall the outcome.
Right.
Sometimes all we can get open is one, and we certainly will take that if there was none before. But I typically try, when I have true critical limb ischemia, particularly if there are gangrenous changes, and particularly if I think there's going to be surgery required, they're going to have to heal surgical wounds. Mm-hmm. So, when we talk about intervention, what's the advantage of it over surgery? Well, when one does surgery, you create a wound to heal a wound.
Correct.
Think about this.
Right.
And so, you're not creating a new wound. Secondly, if there is no outflow at the ankle, we can actually run our wires into the foot and then use the balloons or the atherectomy devices or the stents. None of the stents right now that are presently FDA approved, but there's some in development that we think might be even useful underneath the foot.
Wow.
But there are now things that we can do within the foot to create outflow. And so we're trying to do all of those things. And certainly new techniques have changed the landscape as well. Historically, we did all of this work just from a puncture of an artery in the groin, in the upper leg.
Right.
Now we can gain access all over the body. Now we can do this from vessels in the foot, vessels behind the knees, vessels in the arms. There are many different approaches that we can utilize to cross and then deliver therapy. And sometimes we may use more than one access in the same patient. That allows us to better cross lesions and to treat them. Historically, from interventions, the first problem was people could not cross long blockages. That was the first hurdle. In today's world, with skilled interventionists, that is a distinctly uncommon problem. We can cross almost all of these. Not all, but certainly almost all. And so we've overcome that. We can typically get a vessel open. And what we're really shooting for, we would like that vessel to be open and stay open forever. However, if we get the vessel open, heal a wound, even if that blockage comes back, most of the time, that patient is not going to go on to lose that leg because the body then has enough time to start to build up its natural bypasses. So, we want to get blood supply down there long enough to keep the vessel open. And I like the fact that we're not making a new wound because, for instance, if a bypass is done and that bypass suddenly goes down, now you have two wounds that you're dealing with rather than one. And I think sometimes that's a bigger issue.
Well, that's a very important topic, critical limb ischemia. Through my years of, calling on you there at your practice in Homa and now in Gray, so many patients presented, already at this stage. And for that, you gained a lot of experience on how to treat those patients and a tremendous following. And I appreciate you sharing this information on how to identify it and then certainly how to get serious about it and seek treatment and give yourself the best chance to avoid an amputation, because that is by no means a benign situation once you have that done. I do like the fact that you mentioned, once someone does get an amputation, the burden on their family is tenfold of that of a person that has mobility. So that's something that's often overlooked. Yeah.
Terry, I often hear people say, well, look, I want to get this done locally. And sometimes that's very fine and people can do it. Sometimes that expertise is not provided locally. But, in today's world, I don't understand that argument because getting something done right and saving a limb is worth it. It's a lot cheaper to do that than have the alternatives if the outcomes are not so good.
Correct.
And so, I think this is just an important thing. And I've had patients truly travel from all over the world for limb salvage. It's become a real passion of mine. And I spend a lot of my time not just doing this, but trying to teach people about some of the techniques and things we've learned to help them do this. But right now, we just don't have yet the critical mass we need to treat all of these patients who have critical limb ischemia.
Right. Well, I appreciate you sharing us all this great information and your knowledge on this topic. We're going to come back next week and take this one step further and talk about acute limb ischemia, which is, the absolute most critical of critical patients and how Dr. Walker tackles that situation. Be sure and tune in next week for that important topic.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.